All right. Hello, everyone. My name is Nicole Clement, and I'm a program specialist with the National Rural Health Resource Center. I'd like to welcome you all to today's webinar, Telebehavioral Health Part 2. We're glad you could be here with us, and if you missed Part 1, that is available on our website, and I'll post a link to the webinar playback here in a few minutes. Also, this is the 6th part of this 6-part webinar series, so this wraps up our fiscal year 20 telehealth webinar series. And we'll be sending out more information soon about another series of webinars for fiscal year 2021. So with that, I am going to go ahead and introduce our speakers today. So first we have Robert Stiles. Robert has extensive experience with primary medical, dental, and behavioral health services in the community setting. He has a master's in public health from the University of Kansas School of Medicine, and he is particularly interested in the provision of healthcare services in rural and frontier areas in school-based clinics and services. We also have Dr. Evelyn Nelson, PhD of the University of Kansas Medical Center. She is a psychologist whose responsibilities include project implementation, management, budget management, coordination of evaluation team, and performance of the evaluation section. She also serves as the behavioral pediatrics lead on the ECHO project and oversees behavioral pediatrics services over telemedicine. She oversees the Department of Pediatrics residents, psychology interns, and psychology graduate student participation. She leads the I'm not sure exactly what that is, maybe you can tell us, but in exploring options to increase the availability of specialty services over telemedicine. And then after those two, we also have an RCORE grantee who is going to come and talk to us from South Dakota Critical Access Hospital about telemedicine addiction treatment, so tele-MAT. And then we also have the Alaska Flex program. He's going to share a little bit with us.
Center at Park Nicollet.
Mute. There we go. We also will then have the Alaska Flex program, who is going to tell us about their behavioral health work group. So that is what we have in the way of speakers today. And with that, I'm going to go ahead and turn it over to you, Robert.
Great. I really appreciate that was me. I appreciate the opportunity to present today, and let me get my slideshow started. So we started talking with Terry Hill about this a few months ago, and we're at the Heartland Telehealth Resource Centers. One of the things that we do, so we work on telehealth, and they're a series, then we'll talk about them a little bit at the end. So I know most of you were at the previous session, which I believe we held in August. We ended up not being able to hold it in September, where we talked a little bit about telebehavioral and the concepts and different ways that that's provided. What we're really going to focus on today is looking at how a state flex program may think about the use of telebehavioral health for some of the initiatives and the goals of the flex program. And so really spend a little bit of time talking about critical access hospitals, rural health clinics, and also very interested in sort of the optional areas of flex that relate to EMS, because I think there's a lot of telebehavioral that can really have a very strong impact. And there's a very strong need in rural areas, especially when you talk about behavioral health emergencies that telebehavioral health can assist with. So I'm going to start by talking a little bit about the potential role related to the programs. So first of all, it's very clear, I think anybody who works with rural providers, anybody who works with a rural critical access hospital or rural health clinic, or when we look at community needs assessments, we pretty consistently find that behavioral health is a need in rural and frontier areas. And so this is actually information from the Rural Health Information Hub. 7.3 million non-metropolitan adults had a mental illness in 2019, serious loss of suicide. Really excited that we're going to hear about some substance use treatment and some use of telemat treatment and medication-assisted therapy and other things, because that's a crucial and a very valuable part, right? When you're addicted to substances and the medications like buprenorphine, which I always say that horribly, and others, the idea of having to directly monitor taking those medications, because they can be abused, and being able to do that through telehealth can have some huge benefits. So when we talk about why behavioral health to meet these rural mental health needs, the issues when it comes to behavioral health access in rural areas are accessibility, have to travel a long way, availability, we don't have, right? In the state of Kansas, almost every single county is a mental health shortage area, as well as almost every single county being a medical and dental shortage area. I used to be the director of primary care for the state of Kansas. We were responsible for doing those, and everybody has one, right? There was, at that point, there was one psychiatrist west of Salina, which Salina's not even halfway across the state of Kansas. So you were really out of luck if you needed a psychiatrist out in far western Kansas in terms of doing that in person. And then acceptability. We hear this a lot, that going to a mental health center, going to a mental health office, where your car's in the parking lot, everybody knows your car, can be a real problem in rural areas. The idea of the stigma of seeking this assistance. And so telebehavioral health can be done in locations, and currently even during COVID can be done to the home, to kind of help deal with the stigma of showing up somewhere where everybody knows who you are. It's a small town and they know exactly kind of what happens in that building. So like I said, accessibility, you can get it at home, provider that's some distance away. Availability, there may be more availability of providers that are in an urban area or other parts of the state that can then provide services through telebehavioral health. And then acceptability, it can be done in a location where it doesn't, kind of label you as receiving these services. So just briefly, your state office of rural health directors, the Flex program forward and backwards. Everyone on this call is very aware of it, but just really wanted to point out that when we talk about the program areas, everything except for potentially critical access designation, telebehavioral health can play a role with it. Certainly it can be part of your quality improvement programs, your care transition program, outpatient, financial improvement. Recently did for the Delta Health Summit a discussion on partnership, but one of the things I talked about a lot with partnership is sometimes you try small hospitals. We discussed the town of Fort Scott, Kansas, which their hospital closed. It's been a couple years ago now, and what that town did and what the hospital system did to try to survive, and thinking about behavioral health and some other services that can also make for strong rural health systems and meet the community needs and keep people in the community for care. Population health improvement, obviously, rural EMS, and we'll talk a little bit about some work with rural EMS, and I've heard some great critical access hospitals, support, as well as EMS services that are often, sort of blurred lines between the two in communities. I mean, it's a small community and healthcare all works together and, all know each other and they're kind of all housed close to each other. But in terms of the types of connections you can make and the partnerships you can make, I always say, the way you have to be successful in rural healthcare, right, is you have to be horizontal or vertical, right? That communities are too small, populations are too small, that you either need to have partnerships across broad areas to have a population to make a service possible, or you need to have a vertical so that you're maybe partnering with a hospital system far ways away to get some of those specialty and other services that you're not going to be able to afford to provide at your local level, but also to make those services available locally in a way that keeps people in your community and keeps your hospital and your health system in a rural or frontier community strong. And then obviously innovative model development as well. I think this sort of coordination and integration between behavioral health and medical care is clearly important and an innovative model that has been embraced across the country. So when you talk about the program, the core competencies, it's the same thing, building and sustaining partnerships in local communities and building health systems in local communities, improve processes and efficiencies, quality reporting and improvement, right? We'll talk a little bit about things like accountable care organizations and those types of things, because as we talk about a value-based care system and moving to value-based care, reduce cost. And I know when you talk about a critical access hospital, when you talk about a rural health clinic, the payment model is not based on, unfortunately, value savings, although many times rural health clinics and others participate in accountable care organizations and other types of shared savings opportunities, supporting financial performance, addressing community needs, systems of care, and then preparing for future models of healthcare. So talking about telebehavioral and cause, right? A critical access hospital can do behavioral health and psychiatry as part of what they do as a critical access hospital, as part of their access to specialty services. They could certainly have a contract and work on stabilization when someone shows up in their emergency room, it has to be stabilized, and while a bed is found. Critical access hospitals, there's no rules like there is for rural health clinics. They can serve as the originating or the distant site. So they can be a provider of services as well as a location where services are received. And this can help the critical access hospital make available to the local community and available to the hospital. We've all heard of models like telestroke or tele-ICU, and all of those are the types of things that critical access hospitals may take advantage of in order to meet local needs or to even meet just their ability to perform as a hospital or a health system. Talking about EMS, behavioral health emergencies are one of the most difficult for rural EMS to manage, right? They're not prepared for that. And often local hospitals, I used to be CEO of a federally qualified health center at Lake of the Ozarks, which is a pretty well settled but rural area. And the local hospital, which had over 100 beds, still, if they had an adult in crisis, could maybe watch them in the ICU with 24-hour monitoring while they were finding them a bed because they didn't have a psych unit, right? But when you talk about especially pediatric behavioral health emergencies, those are far, when we talk about Western Kansas, we're talking about trying to get a kid into Denver. And sometimes you can't get a kid into Denver and you can't get them into Kansas City. And you're talking multi-states away. And you're trying to stabilize these types of situations, both with EMS and in the local hospital. So it is currently available you could have an EMS connect to a local hospital for services right now under the COVID public health emergency. And we'll talk a little bit about what you can do in a little bit. It is possible to do services to the home. And so you could have EMS with an iPad and a provider in a local hospital or a provider across the state helping to manage a medical emergency, including a mental health or behavioral health emergency. Obviously, HIPAA still applies. There's been a lot of talk about during the public health emergency about HIPAA. And yes, there is some discretion on enforcement, but it has not been waived. So if you do something egregious, my example is always you decide to see your patients in the middle of a busy Starbucks where everybody can overhear what's happening. I think the Office of Civil Rights and the others that enforce HIPAA would have some problems with that. So I understand critical access hospital, Plex is a critical access hospital program, but when we talk about critical access hospitals, we have to talk about rural health clinics because they are the rural primary care that's often, very much cohabiting and often, to be honest, owned by critical access hospitals. So as you see, 60.4% of cause managed rural health clinics, 38.4% had skilled nursing. Other things though, and I was really interested and I really appreciate the information the Rural Health Information Hub has, this Illinois survey that talks about critical access hospitals that operated dental offices. And I recently working with Great Plains Health Alliance here in Kansas, there's been some interest in a hospital in dentistry, and that's another area that I've worked a lot in. As an FQHC director, I ran dental clinics, and so I've been working with them a little bit on how they can do that. And there's some difficulties for a critical access hospital. It's very hard for a hospital to, we can talk about that another day, but it's very difficult for a hospital to run a dental clinic. And we could talk about why that is some other time. Mental health practices, and we're most interested in community wellness and behavioral health. So, right, this is what we're talking about today. And these are some real opportunities when it comes to the Flex program. So it is important to remember this whole prohibition that hopefully will soon be gone. And right now is not exempt because of the public health emergencies. But rural health clinics outside of the public health emergency can only bill Medicare for telehealth as the originating site prior, they can't be a distant site, right? And that billing for distance and being able to provide those services and maybe offer those services into the community in a community setting like a school under the public health emergency is not allowable, but is allowable under the public health emergency, but it's not outside of that. This is not the same as employing a provider who sees your patient through virtual means, right? Telestroke, many things we've talked about, and it's certainly a critical access hospital can do a bill for. But payment when serving is both the distance and the originating site, right? So you can do that as one entity. But if you're an RHC, under the rules, right? The pre-COVID rules, they still can't bill that distance site outside of the public health emergency. And I know this is very complex. I do entire hour-long presentations on this, but just really wanted to kind of bring some of those issues up because I always want to be clear and straightforward and make sure that I'm not offering or proposing something without clearly explaining what the limits are or the issues. Hopefully, one of the things we'll talk about is that there is a lot of interest in Congress across the board in getting rid of this whole distance site prohibition for rural health clinics and federally qualified health centers. And I really believe that's going to happen. I don't know when, because as we all know, Congress doesn't always do even what they want to do, right? Everybody can agree on something that still may not happen. But given the number of telehealth bills that are out there to try to institutionalize and make some changes permanent that we've seen during the public health emergency, and every bill I'm aware of from every perspective, from Republican to Democrat, across the board, agrees that removing the rural health prohibition, right, that which doesn't matter for access hospitals as much, the idea that you can't do telehealth in urban areas for some types of providers, but also this distance site provision for rural health clinics and FQHCs. I believe they'll fully, as soon as Congress can get their act together enough to pass something to attach that to, it will happen, because there's strong support across the board and there's really nobody against it. So just to be very clear, CARES Act, these are kind of the types of things. RCs can be distance site, reimbursed for the same as telehealth services under the Medicare physician fee schedule. Like I said, significant legislative support for continuing after the pandemic. And they can have relationships with provisional health care to their person for their patients. And some of the places for a rural health clinic that this may be valuable are things like value-based care payment, those ACO objectives with shared savings, chief patient-centered medical home, or other certifications. Certainly, if you want to, if you're becoming a patient-centered medical home, a lot of the things that you need to do have behavioral health components, and the addition of behavioral health services and the integration of these services can be really beneficial. And like I said, during the public health emergency, RHCs can serve as a distance site, and it's billable as an RHC service during the public health emergency, which for now we're sure will be through the rest of this year. Pretty much positive it will be through the rest of next year, but we'll see what happens after that. So just some questions after each of our sections, just kind of thinking about where do you see potential for telebehavioral health to support the critical access hospitals in your state. Here's some ideas that been out there: rural health networks, regionalization, improved access to hospitals or other services, field stabilization for emergency rooms or for EMS, patient monitoring. So I want to talk a little bit, and I'm going to pass off to Evelyn Nelson, about a program that actually works with a number of critical access hospitals across Western Kansas that was funded through a grant through HRSA's Office for the Advancement of Telehealth. And so pass off to Evelyn and you can just tell me next slide whenever you're ready to move forward, Evelyn.
Okay, super. Thanks, Robert. So I'm going to describe the Care Collaborative's work with telehealth. I think today's a good day for me to present, just to reinforce that we've seen success after we built with the Care Collaborative over the last 3 years. Our Care Collaborative is the region's largest rural accountable care organization, and the project's a partnership with the ACO, with the rural practices, and then with specialists at our academic health center. And I think this slide is one that you might see similar in many of the states represented on the call, just real challenges with behavioral health. In our area in Kansas, we ranked 32nd in the nation for access to behavioral health services. Over half of Kansas adults with behavioral health concerns don't receive treatment. I'm on the child side, so I know this section isn't as much about kids, but if we're looking at child specialists, that gap in care is even more extreme. So to meet that need, Dr. Bob Mosier and Jody Schmidt were fortunate to secure HRSA funding through the Evidence-Based Telebehavioral Health Program, and really to test things out and build out a model. And again, kind of the punchline is here after being in the 3rd year of the project, really looking at more sustainable services. So with integrating behavioral health into primary care, kind of the take home with this slide is really don't reinvent the wheel. We have learned many adaptive and useful things with integrating behavioral into primary care in the on-site setting. So really, how can we take those really good lessons learned and with telehealth support people who do suffer from both behavioral health concerns and more often than not, just one chronic disease, but multiple chronic diseases. And that's what we'll see here in the next slide. It aligns with the patients that we've been seeing through the ACO's Telebehavioral Health Network. So this is looking at the top 10 health conditions and costs. So it's both good care, but also good business that our ACO is looking at in terms of it being a win-win and better addressing the needs across these top 10 costly conditions, both to increase quality and lower costs. I think with the next slide, we see that what we see with some of those overall costs is what the North Carolina Rural Health Research and Analysis Center found is really those same chronic illnesses as the presentation in rural health clinics. And again, looking at what health psychology and behavioral health strategies we have to help both address the behavioral concern, but also how to support adherence, how to support the other multiple steps in completing both the chronic disease management and the behavioral health. We'll see with that, of course, things around diet management, around a healthy lifestyle. So all of those kinds of things go together with the behavioral health treatments that we're talking about over telehealth. Next slide. So with the ACO project, with the Care Collaborative project, our focus has really been a holistic one. So to focus on the biopsychosocial factors related to physical health, looking at the patient's overall health and well-being. And what we've seen in the pandemic is, of course, how can telehealth and telebehavioral health address some of those patient needs, and then hand in hand, how can it help support the workforce and our healthcare workforce that is also under a great deal of stress and strain. The approach with the Rural Telebehavioral Health Network, it was a partnership across 10 of the sites with the Care Collaborative. The model tried to stay away from pitfalls that some of our early telebehavioral health work had. So with the model used, there were ACO dedicated telehealth coordinators. They actually went to each of the primary care sites and helped present the patients at that site. The idea was doing the scheduling, the paperwork, the interactions, and making it as easy as possible for our primary care partners. Of course, with the pandemic, we saw that shift some, where we were challenged to think through, with patients connecting from home, how do we retain that same primary care and care collaboration, even with the patient being at home. So with that has been some really creative telehealth strategies to connect patient at home, primary care, and our behavioral health services. I think overall, we were hoping for and anticipating improvements in the PHQ-9 with depression, the GAD-7 with anxiety, and the PROMIS with overall behavioral health. The surprise, I think, for the folks involved has been more just the number of appointments that patients are interested in, and really the uptake across age groups and presentations. That's been a really great surprise. And I think what's not been surprising is there's barriers to healthcare that remain. Transportation is still a challenge if there are patients coming to primary care. No-shows are still a challenge. So really thinking through some of those administrative parts has been important for the program to continue. So I hope this gets your gears thinking about what are the biggest need for adult behavioral health services that you're seeing in your state and program. I hope the message that I'm delivering is, if you can think of it in telehealth, you likely can do it. It's just more thinking through, how do we make sure we're translating our strongest possible interventions to telehealth? How can we think about that together early on? And then with what we're doing, how do we make sure it's going toward both our best interventions and addressing some of the social determinants of health and some of the other challenges that we see with our patients who are seeking service? I'll stop there, Robert. I know we have a lot more presentation information.
No, that's perfect. I appreciate it. And I knew that was probably kind of the area, an example that was most applicable and also most easily adapted for the type of work that the Fletcher program does and the types of initiatives that they work, the different states may choose. But wanted to talk a little bit about our work in the community, because I really think this tie to the community and the way that hospitals and rural health clinics can work in their local community and the types of services they can provide. And also because we have a number of different programs that we've worked with related to schools and community-based behavioral health. And just wanted to bring them up. We'll go through them very quickly. One of them is related to EMS, but it's pediatric behavioral health emergencies. See if I can get these slides to go forward. So we started back in 2016 working, providing school telehealth, behavioral health to school districts. We worked with districts in South Central Kansas and Southeast Kansas. And I previously to this was, as I mentioned, the CEO of a federally qualified health center, and actually had school health clinics as well there in very rural areas of the state. One of the things I'll tell you, and I know there are difficulties compared to a federally qualified health center to do school health and school clinics, but we began in Richland, Missouri, in the Lake of the Ozarks area, because we started hearing from our community that the two things that were needed were dental services and behavioral health services, and that they needed services in the community and not in our clinics. So we began in 2017 offering some services in a local, three local school districts actually. And one thing we found over time, actually, we found some communities that were so small that they couldn't really handle. One of them had a rural health clinic that had closed in the past, but we were able to open clinics that were sort of merged, where I always said, they're kind of, you have one door that the community enters, one door that the school enters. And between providing services in the school district and to school staff and to school students, as well as to members of the community, and this is a school district with 400 kids in a town with 900 people, we were able to open sort of a merged clinic there. And there have been some other entities I know of another a rural health network, FQHC in Missouri, that after that point actually moved their clinic in a town where it wasn't doing well, so that it was accessible to the school so they could provide both community services and school-based services. So with that program, we really work on sort of having a very strong overarching system of care that's not just therapy. One of the things I lecture a lot and say over and over and over is we need, our goal is less therapists, but in addition, it's less doctors and less medical staff, because we need to work on those things in the community that are making a community unhealthy, right? One of the problems of how the critical access hospital program and the rural health clinic, some of the payments and different things really make it hard to decrease care, right? Because you get paid for care. And so hopefully through things like ACOs and other value-based models, and even incentives that private insurance and Medicaid and Medicare provide, we can start to see ways that we can get paid or be financially sustainable by keeping people healthy. So we, about a year ago now, received a $1 million grant focused on behavioral health and needs related to the community impacted by disasters. And so this is that same thing of across a community intervention. So yes, intensive, right? The types of services we're talking about today that a critical access hospital may use or make accessible in their community for some of the partnerships they can do. But also sort of some short-term interventions, things like after a disaster, right? Helping people with their immediate needs. And one of the things that we learned through this process is that if you have a tornado or a flood or whatever, your first business isn't to help people deal with the traumatic incident, right? Deal with the psychological effects, you can actually exacerbate those effects. The first thing to do is figure out, what do they need? Do you need food, water, housing? Do you need to find your family? Do you need a cell phone? So we've done a lot of work on training on things like skills for psychological recovery and psychological first aid. And then, this idea of across a community, making a healthier community. In education, we talk about trauma. In behavioral health, we talk about trauma. I know, coming from a medical setting, I thought of trauma as the 4-car accident. But trauma, is a range of things, ranging from things like experiencing a flood or a tornado, experiencing the death of a loved one, as well as the social determinants and those other aspects that a child grows up having to sort of deal with, and that often puts them at a disadvantage, or requires them to need treatment services due to sort of their response to those circumstances or experiences in their life. So kind of moving from our work in that area, we move into
They show you how to create and edit relationships between contacts and accounts. So you can.
So Telehealth Rocks Together is a recent grant that we just received. And our goal with that is to enhance pediatric health and behavioral health in communities. And what's really interesting about this is it includes a range of telemetry activities. One thing that we do a lot is work to train at the local level, work with clinicians at the local level to train them in things like child-adult relationship enhancement, to train in things like skills for psychological recovery, so that communities are resilient and ready and able to meet the needs of their local community. With that, we partner with Rural Telemetry Training Center at University of Texas San Antonio, and we're using an echo telemetry model. And this type of training approach that we use, we've been doing now for a number of years, and very active and very successful with it, and have really been able to offer things across the board, ranging from skills for psychological recovery. We had a weekly for a while, a COVID echo, just kind of helping people keep up with, how do I provide healthcare under COVID, and really with that big focus on everything transitioning for that period to telehealth. So really big fan of the echo telemetry model. So these are the types of trainings that we've done over the last year with the Can Do and the other programs. So you can kind of see the work that we've done that really works on having healthier communities and having the expertise at the local level to deal with these types of things. And then, of course, we use the Project Echo model, which began at the University of Mexico. It's a guided practice model. It's a collaborative, model where people are working together and learning together and practicing what they're learning. So here's some of the recent echoes that we've had. And I don't have our COVID echoes from the other ones on here. These are just the pediatric ones, but we've done suicide prevention response. That's been a very successful echo. And we have actually in the next year, we'll be continuing some work in that area with some of our training funds, because we're hearing from local communities that's still a substantial need. Looking at better behavior and behaviors related to COVID. Kids, we about a year ago went to school districts right in August of 2020 and said, everything's a mess, right? And we don't know what you need from us. How can we help you as you're looking at returning to school, with a lot of schools having been out of session for the spring, after March when things happen. And they said they needed resilience and self-care, right? This idea of like, how do you take care of yourself? How do you stay healthy with everything we're dealing with? And the other thing was to respond to some of the behaviors that were exacerbated by COVID. So we did that, did echoes and work on resilience and self-care. In the spring, worked on children. This partnership between school and medical care, right? So we had the head of Children's Mercy Hospital, their complex medical clinic, as well as the lead for Telehealth Systems medical complexity clinic. Really lead a really school-focused and community-focused. How do you manage complex medical children in the community, and how do you have a strong partnership with medical providers? We're working on food allergy education, helping people learn how to manage a food, an allergic reaction in a community setting. And you can see, did some guidelines for psychotropic medication, psychological first aid, so lots of different things related to that. And then the second grant that we recently received, and I'm really excited about, is it involves the use of community health workers, which I come from migrant health. That's where I started in healthcare, back to the promotora model, speaking about lay leaders in migrant camps that worked with women on getting breast exams, prenatal care, and really comes out of that model. And then I worked with the low German population in Southwest Kansas that moved in and or strong parts of the farm worker community, right? This is a population that speaks Low German. They're often illiterate in any language, and they're also very isolated culturally. And so we're able to work with some Low German women who became promotores for us and really help manage at the local level care. So, in this telehealth rocks communities, we're really moving into this idea of consumer-directed care, right? We partner with local communities, we partner with local clinics, we partner with school districts substantially, but really helping move into, sort of empowered knowledge of, working with people in the community to learn how to access the services they need, and really excited to begin to bring community health workers into the setting. When I was in Missouri with school districts, we are fortunate the state of Missouri had a pilot. They were really excited to try the Medicaid program community health workers. They found it so successful so quickly that they moved it statewide rapidly in terms of the federally qualified health centers being able to employ, use some of the state funding that went to community health centers to fund community health workers to use in their clinics. And we used that funding to actually put community health workers in schools. And so side by side in a school, we would have medical staff, we would have behavioral health staff, and we would have community health workers working on social determinants and all those other community needs that impacted a child's and family's ability to be successful and to hopefully lead to healthier communities and people that were more empowered and were healthier. And so there's a lot of potential for cost savings, improved health, and just a huge fan of the use of community health workers. And I'm really excited that it's kind of hitting seems like it's hitting a moment where we keep hearing about it everywhere we go. Through the Telehealth Resource Center, we're getting a lot of requests and people finding out about I met with the ALS for the region, the society who's looking at using community health workers to access people with ALS in very rural areas to manage their healthcare and their access to the resources they need. There's some work with community health workers on COVID that's just come about using some of the federal COVID funds. And so it's just been really interesting to see that this is a great solution to helping empower people and also helping to lead to healthier communities. So you can kind of see with that program, sort of the work that we do and how that's all going to function. And it's the same sort of pyramid. We're big on pyramids. This layers of services, that it's not just about those things at the top where people get therapy or get behavioral health services or get medical services. And that's what are billable. It also leads to us training and empowering the community so that the community is acting together. And we're working very hard to have bring collaborative activities across the community together to lead to healthier communities. So I wanted to bring up the EMS for Children Collaborative, which we participated in from June through July, through January through June of this year. And now it's continuing on and then beginning to move into some other things. And hopefully there'll be some implementation funds. So that was a partnership with the Kansas Department of Health and Environment, Children's Mercy Hospital, Harmon Health Resource Center. So our goals for it were to enhance access to emergency care through the use of telehealth and to assess, develop, and disseminate best practices. So did a statewide scan, did a lot of listening and talking to different types of rural providers, critical access hospitals, federally qualified health centers, just across the gamut, rural health clinics. And really beginning just recently, a pediatric behavioral health emergencies community practice that'll begin later this month, and it'll focus on the de-escalation for children in an acute crisis situation, which is a massive and major need when it comes to children's EMS, pediatric EMS. So thinking about the use of pediatric behavioral health and types of things that you can do, suicide prevention, pediatric psychiatry, pediatric psychology or therapy, other behavioral health visits. And I would not stress enough, I cannot stress enough, when you talk about EMS in one of the biggest areas of need, because there are just not the resources in rural and frontier areas, pediatric behavioral health emergencies are crucial. And if someone can come up with some innovative approaches to really figuring out how to help help local communities deal with kids in acute crises, I know there would be a lot of interest in it, because we see that time and time again. It's just a need. Very difficult for adults to deal with EMS in a number of situations, to deal with this type of situation, and we hear on sort of people being shot and other things as a result of interacting with emergency services and some of the behaviors and issues. And it's even more difficult to manage in a pediatric patient. So want to finish, we have just a couple minutes, but wanted to make sure we tell briefly just about how or why you may want to reach out to your telehealth resource center. for your state as you, or to one of the 2 national centers, as you think about the types of things with your Flex program or working in your rural areas of your state. So I'll let Evelyn talk a little bit about kind of what we are, just to remind everyone.
Sure. It's just this last part is a great punchline. It's just really, hey, it's really exciting times. I've been a telepsychologist for over 20 years. The technology is faster, cheaper, better. But I think the really exciting part is some of the things you heard with how do we get better systems? How do we do the prevention, intervention, and follow up? And the Telehealth Resource Centers really can help with that kind of planning from starting telehealth, thinking through business plans and evaluation, and kind of narrowing in on one service to start with, and then helping throughout the starting of the project, the pilot testing, and then onto the sustainability side. So please do keep your telehealth resource centers in mind. I believe we're sharing the link for this as well. There's 14 telehealth resource centers, 12 regional and 2 national, that really are there to help with your questions, and really to share some lessons learned across programs, and then to help tailor the information to your particular need. So we're at the Heartland, but we'd always be glad to hear from anybody.
And I'll put the link in the chat to the National Consortium where you can find your local TRC. So thanks so much for listening, and happy to hand it off to our other presenters.
Nicole, you're on mute.
Thank you. Thank you, Robert and Evelyn. If you have any questions for them, you can go ahead and hold on to them and they can answer them at the end, or feel free to put them in the chat as well, and we can continue some conversation there. But for right now, I'm going to turn it over to Michaela Johnson, who is joining us from, not maybe right at the moment, but she works in a critical access hospital in South Dakota with a name that I will definitely say wrong. So I'm going to go ahead and let her say the name of her organization and then talk a little bit about what she does there and the work that they're doing with telemedication assisted treatment. So Michaela, I will turn it over to you.
Hi, so as Nicole said, my name is Michaela Johnson, and I am at Catotas Prairie's Healthcare System. We are located in Sisseton, South Dakota, and are a rural health clinic and critical access hospital. Our community is about 2,500 people, so that kind of gives you an idea as far as how large or small, depending on how you look at it, we are as a rural facility. I am a pharmacist at our facility, and then I also oversee our development of our substance use disorder services, and something that we just really kicked off probably about a year ago now. As far as actually providing the substance use services at our facility. We really saw a need, oops, I'm sorry, I have my kid here too, so. We really saw a need for these services through the patients that we were seeing in our emergency room, in our hospital, in our clinics, as well as just through stakeholders in our community that were encountering individuals with substance use disorders. So our Department of Social Services, law enforcement, schools, things like that. And really identifying, especially the individuals that we were seeing through our healthcare system, that as a rural community, we really didn't have a lot of resources or treatment options for them. Oftentimes we were trying to connect them to either intensive outpatient treatment or an inpatient treatment service. And that really meant taking that individual out of the community. Sometimes they have other responsibilities, such as children or jobs or things like that, that would really be barriers to them wanting to leave the community to get treatment. So we started looking at, what are our options that we could provide our small community with to be able to support these individuals. And we started looking at developing substance use disorder treatment services. And we're able to apply for a grant opportunity specific to rural healthcare systems through HRSA's RCORP program, which is the Rural Community Opioid Response Program is what RCORP stands for. They have a lot of grant opportunities available specifically for rural communities. So we applied for and were awarded funding for our project we're just entering year 3. So we're 2 years into our 3-year project through that funding. And what we did was we really looked at what our needs were and how we wanted the program to be structured. And our top priorities were flexibility and fluidity, low barrier access to care. So we were looking at our family practice model, looking at, again, as a rural facility, what was the capacity for our in-house providers to be able to provide substance use treatment, specifically medication-assisted treatment is what we were looking at. And started connecting with, it's a small world once you get into talking about substance use treatment, especially in some of these smaller states that are more sparse. And we got connected with a clinic that is across the state from us, about 7 hours away from us, actually. And they provide exclusively medication-assisted treatment to the individuals in their community. So that is all that clinic does, is medication-assisted treatment. So we started conversations with them, and it really evolved into deciding, do we want to create a partnership so that they could provide medication-assisted treatment through telehealth to our facility. And they were interested in that, and it really just grew from there. We created our structure with a hub of a nurse care coordinator. So we have an RN nurse care coordinator who is the main contact for anyone in our community that's receiving these services. She does all of the appointment scheduling. She does all of the intake. And patients present to our clinic for their appointments, just like they would for any clinic appointment. She documents everything in the chart for their intake, and then they see a telehealth provider after that privately in an exam room. And then she also provides, after their appointment, provides them support, gets them connected or scheduled for their next appointment, and then also provides other services. So really telehealth or the medication-assisted treatment is just one portion of the services we're providing. We're also providing things like connecting them to primary care services, connecting them to behavioral health or counseling or whatever other needs that they may have. At this time, we have 45 patients enrolled in our program, which is quite a few for a small community like ours. I think a year ago, we started out in July of last year I think we had about 4 patients, and then by November we had around 12 to 15 patients, and it has snowballed since then. And every month we grow and grow, it seems like. So it was really, we identified that there was a need, but I don't think we understood the capacity or the level of need that there were for this type of support and this type of service in our community. Sustainability is another thing that has really been something that we've had to be creative about because we're using primarily telehealth combined with our nurse care coordinator. That telehealth visit is billed by the clinic that's seeing the patient. So we aren't necessarily getting any direct revenue from that patient visit. But we definitely see the benefits of this model, and it's worked so well for us. So that's really been something that we've been exploring our options with. And I think we have some great things in place for that now that we're a year or so into it and have really fallen into our roles. One area that we are getting revenue from for sustainability is that we just bill the telehealth clinic per appointment for a flat fee for the staffing that we're providing for that appointment, as well as for the use of our facility. So, and we're just doing it per appointment that shows up, so that if it's a no-show or something like that, so that the amount that they're paying us every month is completely proportional to the number of patients that they're seeing. So that's been a great model that's worked with them to be able to support us and the services we're providing, but also support the clinic that's providing the services as well. Another area that we have tapped into for sustainability is through utilizing the Health Home program that is provided through Medicaid. So all of our Medicaid patients so far have been eligible for Health Home, which is basically a care coordination program for Medicaid eligible patients. So we've been able to generate revenue through Health Home enrollment with our patients and providing those services. Another area that we're looking into right now, but haven't moved forward on yet, is a telehealth origination fee. And that's just as an origination site for telehealth services. We could be billing that as well. One thing that we've been doing as far as our sustainability plan is really looking carefully at the downstream effect of any type of plan that we put in place, just because we don't want to create any costs that would prevent a patient or create a barrier for accessing care due to cost. So we've really thought out our sustainability plan to be able to balance that sustainability while also being an easy access service to the patients that we're serving.
Wow, great example of, I'm so sorry, were you done?
Yeah, go ahead.
I was just going to say, I think that's such a great example of not completely recreating the wheel. Like the service, the MAT was already happening somewhere nearby, and you guys figured out how to make that work for you without completely, using the R-Corp grants and the tele method. Like, I just think that's such a great example of not recreating the wheel.
Thank you.
Yeah, really cool.
So yeah, that's kind of our program in a nutshell. So.
Great. Thank you so much for joining us today to share that information.
Thank you very much for having me.
Absolutely. All right, Kate Harmon from the Alaska Flex program, you are up. Tell us about your behavioral health work group that your Flex program has been supporting.
Yeah. Let's see. Okay. So I'm Katie Harmon. I'm with the Alaska Flex program. I'm going to talk just a little bit today about Alaska's behavioral health work group, which is a Flex sponsored work group, but then also just a little bit about telehealth generally in Alaska and some other kind of cool behavioral health activities that are going on in Alaska right now. Let's see. So obviously Alaska geographically is huge. And that's something that hasn't changed with COVID. So I think that Alaska started out a little bit ahead in telehealth, especially our tribal health system. So about half of our critical access hospitals are part of the tribal system, and they use a hub and spoke system. So all these tiny little clinics are already connected to specialists at the Alaska Native Medical Center, which is in Anchorage, and they provide a very robust telehealth service. And they were able to scale that up dramatically when the pandemic started, and that included behavioral health services. So patients, for example, are able to meet with their counselors over Zoom from their own home, and they've developed a ton of resources for patients to become more comfortable using telehealth. So they have videos talking about how you access your appointment, what you can expect, how to troubleshoot technical issues. So the telehealth experience for that population is really personalized for their patients, and it's just a really amazing system. And then a lot of our other critical access hospitals in Alaska are already part of a larger system, and so they had a lot of the infrastructure in place to be able to get their telehealth programs up and running. So I think Alaska started a little bit ahead of where some other states were. So the Alaska Behavioral Health Work Group was Flex sponsored, but is organized by the Alaska State Hospital and Nursing Home Association, or ASHNA. And they have done the legwork to get this group going and kept it organized. So this was a work group that started in 2019, and they meet every other month, and we typically have about half of critical access hospitals participating, as well as the larger hospitals in the state, the Alaska Mental Health Trust Authority, someone from the State of Alaska Director's Office represents, and then the North Star Behavioral Health Hospital, which is a for-profit behavioral health hospital in Alaska. And they get together to share best practices and coordinate on shared interests and systems issues that need to be addressed. So, for example, right now in Alaska, and probably in a lot of other states, we're having trouble discharging teens with behavioral health issues from the emergency room. And especially now that the ER is overrun by COVID, they're really struggling trying to figure out what do we do with these kids who don't necessarily have an exit plan to leave the ER. So they've been coming together to try to make a plan for helping those kids out. So they've reported that a lot of the value in the behavioral health work group is just coming together to be able to plan, share lessons learned, commiserate. And then when the pandemic started, it was great because they were already organized. And so they were able to advocate for some of the telehealth flexibilities that they really needed in order to be able to continue to provide behavioral health services. So they were really well prepared for that, which was nice. And then something else kind of telehealth-y that's going on with the behavioral health work group is they have organized an ECHO series. And this is another activity that ASHNA has organized. So they've contracted with physicians and psychiatric nurse consultants to develop a behavioral health curriculum. It's a 12-part series. So they held the first 3, then took a break for summer. And now you guys have probably seen that Alaska is having a crazy COVID surge. And so that's been put on hold, but it will resume when that's appropriate. And the ECHOs are designed to assist medical professionals working in rural areas to manage patients dealing with behavioral health issues, substance use disorders. So that'll be a really valuable training tool. And then something else I just wanted to share that's not telehealth related, but is a cool activity that Alaska did was a de-escalation training that we were able to hold in April. We ended up having some carryover funds, as many programs did. And so this trauma-informed de-escalation training was requested by hospitals who are seeing an increase in workplace violence, which is such a serious issue. And so this was a training that identified primary causes of escalation in hospitals and focused on skills and strategies to support prevention and early intervention within the cycle of escalation. And it had a special emphasis on psychiatric and medical contributing factors and focused on individuals experiencing dementia and serious persistent mental illness to help providers and hospitals get some tools to help break the cycle of escalation to violence. So this was another partnership between ASHNA and our largest hospital in the state, Providence. It was a 2-day train the trainer, hands-on, in-person course, which was great because it happened right before the Delta surge. And so it ended up just being a great use of carryover funds and a really cool, well-timed project that really helped the hospitals out.
Yeah, that is really cool. Thank you for sharing that. Like you said, it's not necessarily telehealth, but still pretty timely. I think we unfortunately are hearing more and more of that violence against healthcare workers, and COVID isn't helping as the hospitals are overrun with patients and trying to figure out who to treat in some cases. And you can see where that sounds fantastic. Thank you for sharing that with us too.
Yeah, thank you so much for inviting me.
Absolutely. Robbie, if you would go ahead and launch the post-education polling questions, that would be fantastic. If you would all take a few minutes to answer these questions now that you have heard the content, that would be fantastic. And again, if you guys have any questions for the speakers, go ahead and put them in the chat. We are right at 3 o'clock, so we are about done with our time. But if you have questions, I'll make sure that they get addressed, and whether that's connecting you with the speaker or answering the question from somebody here in task, we'll make sure your question gets answered. A couple of announcements while you guys are answering those questions. very few actually. We're at the beginning of a program here, just like you guys are. So we're really ramping up and getting our stuff figured out here. But we do have a webinar tomorrow at 2 p.m. Central Time to introduce our new financial guide for the rural healthcare leaders during COVID and post-COVID. And then coming up in November, we have the virtual F4HP Flex program workshop, again, being held virtually over 4 days, November 1st, 3rd, 8th, and 10th. I think that is full, but if there was some need for someone in your office to attend, send us an email and let us know, and we'll see how that works out with the schedule and those already attending. If you've already let us know, I would imagine you'll be getting some information soon to tell you kind of what the next steps are. Dorothy, I see your question about signing up for the Flex workshop, and I will have Matt of our staff reach out to you, as he is our person that's kind of coordinating all of that. So yeah, you're welcome. All right, go ahead and finish answering those 4 questions. Make sure you scroll down in the poll box and see all 4 of them. And once you're done with that, thank you so much for coming to this webinar. I hope you found it useful and have a great day.